So we're going to talk about how to actually go about doing bowel anastomosis. And we're going to be focusing on the technical details. And it's all about the small things that matter. Before we actually get started, we're going to draw a small bowel here and understand the important aspects. So you got your small bowel here, and then you got your blood supply, which is through your mesentery. And so when you look at the small bowel, depending on where it is, it usually has a very floppy mesentery. And you have the mesenteric aspect of your small bowel and then the anti-mesenteric. And from there, when we do a bowel resection, the important thing that you have to consider, number one, is what are your margins? What are you resecting for? And are you resecting to normal tissue? That's number one. So when dividing it and then firing a stapler to divide the bowel, you want to ensure there's going to be multiple ways that you could do it. One is you go straight, which is actually good. You can do that one. Or occasionally, you can actually do this way, have a slight bit of an angle there. But the one thing that you don't want to do is actually cut it this way. The difference is when you cut it this way, the mesentery is shorter, and the question is, will this be prone to any form of ischemia? And in these two other aspects, this is pretty much straight and would have enough blood supply, and then you can look as long as your stapling looks healthy. And in this aspect, you have a shorter anti-mesenteric border, and you have more mesentery present. So that's the first part.
Almost 98% of people watching this aren't subscribed. If you're a medical student or resident who wants to think more clearly, prepare more efficiently, and perform better under pressure, this channel is built for you. Click the like and subscribe button, and let's keep on going.
Of course, if you are resecting a small bowel, you're going to have two pieces. And if we say you resected one end, and then you resected the other end, from here, you're going to have the mesenteric defect. And depending on if you're doing an oncologic resection, then you go all the way down to the base. If you have a really large resection, let's say you took out 30 cm, it would be better to go deeper because the mesenteric defect to close would be larger if you actually left it close to the bowel. If you bevel it all the way to the root of the mesentery, if you had like 30 cm, it would go way down there and way down there. If you stretch this out really far, and then did not go to an angle, you'd have a longer thing to close. So now that we've resected the small bowel, you have to identify which is proximal and which is distal. And then the question would be, how do we put it back? Well, there's going to be several options. You could do an end-to-end if you do a hand sewn. Well, if you did a hand sewn, the pros and cons is does the bowel have the same size of lumen for you to do that if it's an end-to-end? And you want to ensure that they do, because if there's a size discrepancy, it would be better off with either an end to side, because you can close this one with a stapler, open this one up, and then plug it to the side, creating the same length if there's a size discrepancy. So when you put this bowel back together with a stapler, most commonly we do a side-to-side anastomosis. And that is divided into two things. If you put these two things together, here, and then the other bowel here. So we're looking at the top view, and then you create this two. You create a hole here and then a hole here. So you got an enterotomy over the anti-mesenteric border, and fire a stapler, and we're going to use a red to fire a stapler. And then the anastomosis would be here as you fire it. So this is called an isoperistaltic small bowel side-to-side anastomosis. And afterwards, with this hole now going to be bigger after firing the staple, you're going to now close it with a suture, which normally I prefer doing a canal technique using a through a monofilament. What are other ways? And then we'll compare it. The other way to do it, which I prefer, is actually doing an anti-peristaltic. So this is the distal small bowel, and this is the proximal small bowel. So let's put this one proximal, and this is distal. So what I did was flip it this way, so that now they're making a U-turn. So now these are stapled edges here, stapled edges. These are stapled edges here, stapled edges. And so in this one, when you do align them, the important aspect when you do align and then fire that staple, whether in this technique or this, you want to make your common enterotomy, if possible, in the anti-mesenteric border. It doesn't have to be exactly at the anti-mesenteric border. The only thing it must not be is it must not hit the mesentery. Why? Your mesentery has your vasculature and blood supply. So if you fire a staple there, you're more likely to hit some of the vessels. And when you use a stapler, it forms B's, like any other stapler. And each of the staples that fire is designed for a specific staple height. And if that staple height is for bowel, if it hits vessels and then cuts it, you're more likely to bleed because that's not the proper height to deal with it, and you'll have a problem and you may have to go back in and redo your anastomosis. And so you could either do it on the top, you can do it on the side, on each other side, and we do that in bariatrics when we do a jejunojejunostomy, meaning you have one limb that's longer that you then plug in to a common channel like that. And so in this aspect, I do it from there on the 9 o'clock position. This one you can do anti-mesenteric, then you can fire. But going back here, these are both anti-mesenteric. We fire a staple here. Let's actually use the red pen. So we make our enterotomy, and this is the staple line end, staple line end, staple line end. They're both anti-peristaltic. So the proximal goes here, the distal goes there. This is iso-peristaltic. Proximal goes here, and then the distal goes there. They're the same direction. And so we then fire a stapler. We put our stapler here, and then make our common channel there. So there's our anastomosis fired with multiple staples. And then we close the common enterotomy. When we close the common enterotomy, again, I prefer a canal technique, or you could do a two-layered. And then we close the mesenteric defect, because then that would have a V down here. How do I close my mesenteric defect? Understanding that the goal of closing the mesenteric defect is preventing an internal hernia. So if you have a piece of small bowel that actually herniates through the defect, it may actually cause an internal hernia, causing a strangulation, and you don't want that one. I prefer to do a running locking suture coming from here. And so if you do a running locking, it would automatically cinch the vessels if you get into a bleeding. And again, if you're taking the mesentery to close it, you're only taking the visceral peritoneum. And the goal of closing the mesenteric defect is just to close the defect. You don't want to make it bleed, or you don't want to devascularize. Why do we do a running locking? Meaning anytime you take a throw, it basically cinches up there, there. It's a hemostatic suture, so that if you hit a vessel, you just tighten it and it will lock. You don't want to take big bites because then you'll compromise your blood supply. Okay, now we've explained this two type. This is iso, this is anti, and they're both side to side. Side to side anastomosis. So what is the difference? And why do I prefer one versus the other? I actually do both. So for open surgery, I prefer this one because if you think about it, you both have the anastomosis here, but the problem is with the closure of your common enterotomy. What are the two problems? Well, if somebody was closing this and they hit the back wall, meaning they're taking a bite of closing an enterotomy and then they go all the way down here, right there. That would actually cause an obstruction. Well, if you cause an obstruction in this portion here, that could actually impede the flow because your succus would go through this channel, and if this impedes the flow and narrows it down, you're going to have a problem with the flow of the succus. Why not here? If you bite and then take the posterior wall by accident, what would happen? The flow comes from proximal and makes a U-turn because you have the anastomosis with a staple line before the closure of your common channel enterotomy. So it makes a U-turn. Here you have two risks versus one. One is the risk of obstruction, and two is the risk of a leak. Here, there's likely a risk of obstruction because of that pathway of your sulcus, so your only chance is a leak. So I've minimized it overall with 50%. Why do I use this one? Well, when I'm doing robotic surgery, most of your ports, if you're doing a right colectomy, it is quite hard to align an anti-peristaltic small bowel to colon anastomosis based on our port placement. And so in that instance, I actually do a ISO, but being mindful and ensuring that I avoid any of that risk. What are other anastomosis that we do? If you're doing a colorectal surgery. And so if you're doing a colorectal surgery, you have the descending colon if you did a sigmoid colectomy, and we're plugging it to the rectum. And so your rectal stump is here, and this is your mesorectum. We'll put MR there. And this is going to be your colon, which is going to be here. It's going to be mesocolon. Okay, how do we do this? Well, when we do this, these are, again, this could be staple line. And if we do this normally, we cut the end and we actually suture an anvil. So you'll have a purse string suture here that then cinches this one down, and then you will have the anvil of the EEA that's going to deploy to a spike. So when you have an EEA stapler, then it goes transanal, and you have two options. One is to either go through the same division of the staple line, and that will be closer to an end-to-end, or you could actually come out here. It becomes an end-to-side on the anti-mesenteric aspect of your proximal rectum. And so if you go there and deploy the spike will actually go in, and what it would look like is right there. So it becomes an end-to-side, and then you have your mesenteric defect there, and it follows the same principle, creates two anastomotic rings, and then divides them with a stapler, and then we scope afterwards. Other things that you have to consider when things are not going straight forward. Well, you gotta be able to understand how to do a size mismatch. What is a size mismatch? Okay. let's say your colon is this big. Wow, that's a pretty large colon, and then you have a rectum that is this big. So you resected a tumor, and then now there's a size mismatch. Well, if you purse string this one, you're really going to have a hard time because that will cinch it up. And if you look at the stapler on the EEA, the bunched up tissue must go inside the stapler, or else it would actually obstruct or affect the staple line in itself. And so what do we do in this aspect? So here, when you do the resection before you staple this one, what you could do is resect this one with a staple line on your distal segment. You can then, two things, you could either resect this with a cautery or a ligature, keep this open, and then if you look at your EEA, there's going to be a spike that goes with an anvil. Why is that important? When you put the anvil through here, you can deploy the anvil up here to the side. And so it has a plastic spike that you can take off, and then you can deploy it into the anti-mesenteric border. If you deploy it to the anti-mesenteric border, then you can close the colotomy here with a linear stapler. What will happen next? Then you can go to your normal route, in which you will now have this large colon that has now we now have the spike of the anvil here, and then here comes your rectum. And so this is the staple line that you use to close the dilated segment when there's a size mismatch. And then here it goes to the spike that then enters the EA. And so you have either, and this spike can either go to the end or to the anti-mesenteric border. So you could either have a side to end or side to side EEA anastomosis. And you have two staple lines. One is going to be your EEA, the other one is your linear. Actually, the third one's going to be your rectal. So you have a linear on your colon, you have a linear on your rectum, and then you have the EEA, which is your anastomosis. Going back in a regular colorectal anastomosis that we do, you actually resect the proximal staple line of the descending colon. So you have a purse string here and then just one staple line. So if you actually went through here with your EEA, you have only one anastomosis, one staple line, because the circular staple will then go through the linear stapler. If you do a end to side, you'll have a linear stapler and a EEA staple line. And those are important because the leaks can happen in any of the staple lines that we have shown. The important things when making an anastomosis is it should be tension-free. And I think that's more of a misnomer because there's nothing that's really tension-free. It's more of that the anastomosis is not under tension. Number two, it's healthy tissue. You don't want to do it on somebody who's on pressors. Number three, there is no size discrepancy. If there's a size discrepancy, then the tissues are bunched up. You want to address that whether you do a hand sewn or you do a staple to actually provide it with addressing or avoiding a size mismatch. So no size mismatch. To ensure health is ensuring that the margins are clear, that the tissues are non-inflamed. For people with comorbidities, ensuring that they're non-smokers, that increases your leak rate from 45% to up to 20% when you're doing colorectal. Tension-free, how do we avoid this? Adequate mobilization. In the small bowel, that's less likely because we have a lot of small bowel that moves around. But when you're doing descending colon to rectal anastomosis, that's where splenic flexure mobilization comes in. And lastly, when you do all of this anastomosis, pay attention to the small details, ensuring that you're not hitting the mesentery, ensuring that when you fire the staple or get it in, you don't basically try to force it in. You create a proper size enterotomy that the stapler could get in easily. And then when you fire the anastomosis, if it's inflamed, you give it enough time to put pressure so that the staple lines will close properly and give you a good connection. Using the proper staple height, which we'll talk about as well. You could look at the other video, and you could also see in that video how to use the staplers. And lastly, you pre-plan your case on what you're going to do and why you're going to do it. I hope you guys liked the video. If you guys have any questions about putting or troubleshooting anastomosis, we'll talk about more other stuff. I showed a little bit of some forms of bariatrics, some form of colorectal, and some small bowel there. But there's a lot more to talk about. You know, feel free to type it in the chat. If you have any comments, we could probably do a specific video for any suggestion that is related here that needs answering. And check out our other videos, which includes how to do a hands-on anastomosis. And I'll see you guys next time.